keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
I'm Bill Zogby from the Methodist DeBakey Heart and Vascular Center in Houston. And with me today is Dr. Victor Moravi from the University of Chicago and Dr. Sharif Naga from the Methodist and DeBakey Heart and Vascular Center. Welcome. And we will be discussing ventricular dyssynchrony and the role of CRT in that arena. And Victor, you just had published in JACC Imaging a study on the role of 3D in evaluating dyssynchrony. It had some interesting findings. Tell us a little bit about the study.
So in this study, we studied two groups of patients, patients with normal left ventricular function and patients with a dilated cardiomyopathy. And each of these groups had two subgroups with and without a left bundle branch block. And the findings were very interesting and somewhat unexpected, because what we found was that in normal subjects, the presence of LBBB made a huge difference in the index of dyssynchrony calculated from 3D echo images, whereas in patients with dilated cardiomyopathy who potentially are supposed to benefit from a more accurate referral criteria, the presence of LBBB made a very small difference. And our study was actually designed to investigate the reasons why this is happening in those patients.
So in the normal individuals, we had a very low, what we call standard deviation in the contraction of the wall motion, and individuals with cardiomyopathy, irrespective of a bundled branch block or no bundled branch block, almost normal QRS complex, you had a large dyssynchrony with them. And this is somewhat an unexpected finding.
That is absolutely correct.
Why do you think so?
Well, what we found was that the definition of the index of dyssynchrony as a standard deviation of the timing to end of ejection in different segments is such that even if there is one segment that has a slightly different time of end of ejection, the increase in the standard deviation can be very, very significant. And what happens, especially in patients with dilated cardiomyopathy, that when the ventricles are very hypodynamic, then the changes in volume are minimal and the curves are very, very flat. So if you add a little bit of noise to these curves, you can detect the peaks in different places that have nothing to do with true dyssynchrony. And this is the reason why we're getting this huge standard deviation in these patients.
Sharif, you've written an editorial to the manuscript regarding these findings. Your perspective on it, meaning one is this limitation with current technology, how conceivably we could get around it or improve it down the line, and maybe other ways of looking at dyssynchrony with 3D.
Part of the problems with 3D echocardiography has to do with technical aspects. So having a lower frame rate is a disadvantage in comparison with other echocardiographic techniques. For example, in that study, the data was acquired from 8 cardiac cycles as opposed from 1 cardiac cycle, which is what is done with tissue Doppler. Image quality and adequate endocardial border detection throughout the duration of systole is important, and Victor alluded to the problems that happen with that. A third element that is also a problem is the approach itself. Standard deviation is affected by a single outlier. So perhaps other analytic approaches where they look at not simply whether one segment is delayed compared to other, but how many segments, how they are clustered, and possibly also how much of a delay you're looking at as opposed to just one is delayed more than the other.
So from your perspective, both of you, it looks like, yes, we are somewhat limited with current technology, but I think with the advancement in technology now of 1 frame rate, 2 endocardial resolution, 3 the ability to acquire in a single beat, basically your 3D, conceivably, that technology could still go forward in assessment of dyssynchrony. Do you guys agree with that?
I agree, and I think 3D has a very nice appeal in that it shows the areas that have the most delayed contraction, how close they are to the venous system. This data could be combined together, and even non-imaging cardiologists can appreciate its implications.
Well, thank you very much for having you, and we appreciate your perspective, and that's a very nice study, Victor.
Thank you very much.
Thank you again for joining.